So welcome everybody to the meeting of the Health and Wellbeing and Overview Scrutiny meeting of the 1st of March 2022. The meeting is being live streamed via YouTube at Northumberland TV. Can I just remind you that your phone should be on silent or switched off. I welcome everybody to the meeting and our guests today. Thank you very much. Apologies for absence. I've got apologies from Councillor David Ferguson and Councillor Cliff Humphrey. Do I have any other apologies? Everybody's here? Everybody's here? Yeah. Disclosure of members' interest. Do have any member any disclosures of interest on this item agenda? No. Note the forward plan. Sorry, I did you check. Are there any items that affect this committee? I don't think there are there? No. No? Nothing on the forward plan that affects this committee. So we go to the reports for consideration by scrutiny, and the first on the agenda is the Northumberland Palliative Care and End of Life Strategy. And I'll welcome our guests, Mr Alan Bell, who's the Senior Head of Commissioning at Northumberland CCG, and Mr Andrew Stewart, who's the GP Lead, to discuss or to explain the revision of the End of Life Strategy. Thank you.
Thank you very much. So yes, I've got a short presentation and then very happy to answer any questions. I'm just... Right, technology is working. Thank you. So yes, around 2.5 years ago, there was a challenge from OSC, or Breeding Scrutiny Committee, around reviewing end-of-life strategy and updating that to make sure it's current with reflecting of current policy and making sure that it really reflects the health and social care system in Northumberland, and also making sure that it captures the voluntary sector and community groups as well. And also there was an ask to make sure that we engage with the local population, including those hard to reach groups. And in terms of making sure that strategy wasn't just about hospital care, but also outside in the community and within people's homes. So how we set about doing that. So in terms of how we set about doing that, we formed a task and finish group. So that was a collaborative group that formed a number of representatives from across the health and care system within Northumberland. So we had 3 local councils originally, a patient representative, a health watcher on that group, social care senior management and secondary care palliative care consultant lead, also the geriatrician who works in the hospital and in the community, palliative care community nursing leads, public health analysts both in the acute trust and across social care, communication engagements leads, and also myself and Andy CCG GP lead for this area. We first met in January 2020, and then unfortunately there was a pause during COVID, and then we met virtually throughout the latter part of 2020, and then met continued to meet virtually throughout 2020 to develop the strategy. As part of that work, we approached it by developing a work plan, and that task and finish group formed that work plan over 3 areas. So the first really was around understanding the data. So there's a wealth of data around end-of-life care out for us to access, and we were looking at what does that tell us, and also how can we make best use of that data. The second element of it was that service mapping, so looking at professional and clinical engagement to understand current pathways, also looking at in the community and in hospital, and looking at that service mapping to identify what we're doing well, but also what gaps and what we can do to address those gaps. And the third important section was around engagement and ensuring we followed that original ask to ensure we had a comprehensive discussion engagement with public patients and the voluntary sector around end-of-life care. So in terms of from that, we look to develop a future plan, looking at priorities and defining how we'd monitor that success in end-of-life strategy. In terms of, as well as that, we would look at, and we have developed a strategy around communications and how we'd roll out our end-of-life strategy. Okay. So the first element of that, which I've just discussed, was around understanding the data, and there was, fair to say, a wide range of data sources, and with our colleagues from the public health analytic teams really trying to drill down on that data, understand what it's telling us. Our public health colleagues helped us a lot with a Tableau dashboard, which is a basic dashboard which shows you the information and gives a way of presenting it which can be easily looked at and interpreted by a range of individuals, and we hope to launch that to public as well, so that can be viewed. So it includes a range of data sources, includes cause of death, demographics, place of death. There's a graphical representation, so you can drill down to the individual wards across Northumberland, and it gives you things like a year-on-year comparison and the different mortality rates. So the next slide is just an example of that. I appreciate it might be quite small, but certainly in the next coming weeks, we'll publish a live dashboard through public health colleagues, which enables you to drill down to individual wards in Northumberland and actually see what the data is shown as within each ward, and represents by things like age, gender, and the causes of death around Northumberland. The next slide is just some of the other data we collected, which we found interesting, was around comparing ourselves to our peers across the region, but also nationally. We looked at data. So this slide just shows, in terms of proportion of palliative care patient or deceased patients who died in their place of death. Now, the purple line, the top line's Northumberland CCG, and you can see our percentage in terms of that proportion of people who've died in the preferred place of death is higher than the rest of the region. Now, there are a number of possible reasons, and certainly from a healthcare perspective, there was a lot of work by GP practice and primary care in the previous 5 to 6 years around making sure death or preference of death was recorded. So that's just an example of other data we collected. The next slide, just in terms of service mapping and how we approached that, we quickly found that the National Council for End of Life had a series of ambitions. So that overarching ambition from that National Council, I'll just read it out. So, I can make the last stage of my life as good as possible because everyone works together confidently, honestly and consistently to help me and the people who are important to me, including my carers. So in terms of that end of life National Council ambitions, they have developed 6 ambitions, which each person is seen as an individual. Each person gets fair access to care, maximising comfort and well-being, care is coordinated and all staff are prepared to care, and each community is prepared to help. So within those ambitions, the Task and Finish group found it was quite a nice way of breaking down end-of-life care into the different elements, and this was a process we used to actually map or use building blocks to understand actually what is going around or on in Northumberland. So for each of those six ambitions, we actually used a mapping exercise which we asked our colleagues across the health and care system to answer. So that's just an example for ambition 1. So for example, one of the building blocks was around effective systems in place to reach patients who are approaching that end of life. So for that particular statement, colleagues in both secondary care and in the community were asked to provide information on how that building block, how that statement was achieved, or perhaps also gaps within that those building blocks, and that also was collected information from the voluntary and community sectors and hospice providers. In terms of engagement, the group in the initial stages looked at quite a significant number of different reports, and it's fair to say both nationally and locally, there were quite a few different bits of engagement and previous reports which we analysed at the very beginning. So, for example, that Good Death Charter, which was done in 2010, so not so long ago, and that covered the North East region. But there were also a number of other reports, such as the National Every Moment Counts and the End of Life Care Report in 2018, which was more recent. As part of that, certainly with our colleagues within the engagement team, there was a comprehensive engagement process conducted in 2021. That was both online and in person, so in the former stages, some of the engagement was done online, but there was obviously a need to do that in person as well, and that was seen as an important element of making sure that we captured a range of views. So in terms of, certainly there was engagement work which we thanked Health Watch for doing, which was very comprehensive. There was an independent organisation asked to do qualitative and quantitative research, and that included a citizens panel and also targeting those with protected characteristics, which there's a full report which we can share. Also in terms of, there was public focus groups and involvement from that voluntary sector. Also in terms of staff groups, there was a number of engagement sessions with different staff groups around the health and care system within Northumberland. So in terms of that engagement material, that ultimately reflected how we approached those 6 ambition areas, and also helped understand from a mapping point of view what those 6 ambitions were, what we're doing well from an engagement and public perspective, and potentially what other gaps there were. As part of that work as well, we also looked at the concept of our community together, so a social contract or a piece of work which looks at how we all, so the patient, public in Northumberland and health and care colleagues, all work together to make things better around end-of-life care and palliative care. So next slide. In terms of our priorities for each of the ambitions, broke it down into looking at actually what is the best practice, understanding what variation there is around the county, so that Tableau Dashboard I talked about before enables us to do that, because there is a significant amount of data, and then also looking at what those gaps in service provision are across Northumberland, and then looking at what priorities and then what outcome measures, so that the report document that they produced, within that there's a set of tables which sets out some of the gaps and all of the gaps we've identified, what those priorities are, and also the outcome measures. As part of understanding how we go forwards from that point in terms of addressing gaps and how we continue to ensure high quality palliative care within Northumberland, we propose to develop a monitoring group for that, and the sort of 5 high level ambitions for that group, just to ensure all residents have access to palliative care support at the time they need it, ensuring promotion of our community commitment across Northumberland, and that's so that residents know what they can expect from palliative care and end of life. In terms of regularly reviewing whether we have delivered on our palliative care and end of life priorities to embed best practice, and also close any regional gaps or any gaps nationally that we've identified through any of the data or other sources of information we've got, and also understanding of that full end-of-life pathway and appreciation of people's different preferences and what they would like at that end-of-life time. And also, if there's inequalities, highlight those inequalities and identifying ways to address those inequalities. Within your pack as well, we talked about the communication approach. So our objectives in terms of making sure that we communicate this effectively across Northumberland, working with our communications team to look at the objectives of making sure that we're presenting information which is in an easily to accessible format and to clear around our strategy, to encourage that conversation and really around our community commitment. That's about actually understanding from each of us what a good death looks like, and encouraging those discussions between loved ones and between care providers about how we ensure that happens, and ensuring that taboo around death and dying, and making sure that we have an open conversation about what we expect and what's required at that difficult time sometimes. In terms of an approach, so I've already talked about our community commitment, and there's a draft mock-up of the booklet within there, within the pack, which was distributed. And also there's an approach to how we make sure that the information that we submit is available on a range of different platforms and accessible to all residents in Northumberland, and also the concept of a death cafe and toolkit, and making sure that the places where people can go to get more support and have more conversations if they so wish. So it's just an example of the booklet which is in your packs, and ultimately I think some of that is about us setting down exactly what we will do and what we want residents in Northumberland to do, and setting up a principle of actually we're all in this together in terms of what we'll do around that strategy development and end of life care to make sure that it's high quality. So in conclusion, we've produced a comprehensive refresh of that Northumberland palliative care and end of life strategy, and there are plans in place through the group that I've talked about and around taking forwards the priorities and ensuring that high quality care continues across Northumberland. Certainly we've got a comprehensive communication plan to encourage the rollout of the strategy and encourage support through the social contract, or our community commitment. And I guess to say this is, as we see at the start of our journey, to ensure that strategy is embedded and in place, and we continue to monitor that through the various different groups that we are proposing to put in place. Thank you.
Thank you. Did you, sorry, it's Mr. Bell, isn't it? Did you want to say anything?
No, I think we would quite happy to take questions,
Take questions,
from the floor,
yeah.
if I can help out there.
That's lovely, thank you. So I'm going to take questions, and I know that the committee were really keen to have this on the agenda, so I'm assuming they've got a pile of questions. I'm actually going to start, though, to see if Derry from Health Watch has any questions, because I know she has to leave at some point earlier than when they finish.
Oh, thank you. I mean, I think I will start by saying we were very pleased to be involved in this piece of work and around the engagement, and I think about services, and I think that's what's really good that's come out of this, and certainly our community commitment I think will be useful. I've spoken to
I'll open it up now and questions. Councillor Hill, Councillor Hunter, I think, did Councillor Nisbet have a question? No. No. So in that case it's Councillor Dodd. So it's Councillor Hill, Councillor Hunter, Councillor Dodd.
Thank you. There was, there's been a recent report published, and I think one of the authors is Michael Ashcroft. And this is the NHS in general, it's not just in this county. And his findings, and emphasise his findings, not seen as a sort of objective that this is a fact, but this is his research, what he's found, that often dying patients are taken from hospitals into hospices inappropriately and not in the right reason, and said there's so much pressure on the statistics that's the reason that's happening. And I thought that was an interesting, quite a serious finding, if that's the case, and I just would be interested to get your response to that.
Thank you. I don't think I've actually seen that particular report that you're referring to, but I think you may be suggesting that maybe some patients who may be approaching palliative care end of life and not being managed maybe in the most appropriate beds to meet their needs.
No, I mean, he's saying that patients be moved from hospitals to hospices.
Right.
And the charge is that is predominantly to do with statistics, not, you know, dying in hospital and so on, as opposed to the needs of the patient.
Yeah, I suppose we would make the case, and certainly the report makes the case, that when patients are approaching end-of-life care, we should be respecting their wishes, whether that's they wish to die in a hospice setting, wish to die at home, and certainly we would make every effort to respect those wishes, as opposed to say, dying on an acute medical ward, where, so sort of being supported to die at home or a hospice, we can meet their more holistic needs, and that's certainly one of the priorities we flag up in this report. And I suppose that's reflected to some extent in the data, which shows that 40% of patients are supported to die in their preferred place of care. But that doesn't mean that a lot more work still needs to be done to respect those patients' wishes. So it's important that we understand patients' preferences for end-of-life care and how we can meet those. Does that answer your question?
Not exactly. I mean, I know that this is and you haven't read the report, and this is a sort of a wider issue. I mean, we always have this problem that happens in education, it certainly happens in health. You need performance indicators, you need data, and we all look at the data to scrutinise. But sometimes there can be a problem with chasing statistics, the huge pressure. I mean, are you aware of any performance targets that could potentially lead to not wanting people to die in hospitals and therefore moving them to hospices, which sometimes might be appropriate, but other times it wouldn't be?
No, not at all. I'm not aware of any sort of drives within hospital to move patients from an acute hospital setting to a hospice other than to meet the patient's holistic needs. So there wouldn't be a sort of a national driver to move them out other than that. Really, a hospice setting, whether that's, and particularly for Northumberland, that would be more the sort of the community hospital type beds, for example, Holt Whistle, Alnwick, Berwick, and the palliative care unit at Wansbeck, which are much more geared up to meeting patients' holistic needs to end of life. So the drive would be to get patients who are perceived to be end of life into those beds, but that's for the benefit of the patient rather than any particular statistics to move the patient out. So it would be the drivers would be for the patient's care, but I'm not aware of any other drivers than that. And certainly, you know, we do collect data about patients' preferences, both in the community and when they come into hospital. I probably would be quite helpful if you would be able to. I'll have a look at that report and read it in the context of our palliative care strategy. I think that would be quite good. I'm sure we'll be able to get a copy of that. So good. Okay.
Okay. Thank you, Councillor Hill, and thank you, Councillor Hunter.
Thank you. I know up in the north and the Berwick area, we're limited on the palliative care availabilities within the hospital, and currently when we're getting redeveloped at the minute, but again, you know, if there's not the support there, then they end up somewhere like NSEC and that, which to people, especially the older people, it's end-of-life care. They may not have transport, they may not have local family, because not always family stays local nowadays. And it's how they actually get there. You know, they're in a stressful situation and the transport links to there is not very good. And also reading on page 8 of your report, it's on about how the support's there for 8:30 till 5 o'clock Monday to Friday, and not bank holidays and that. You know, we can't guarantee that everybody can fit into that element. And it's that fact, if something happens at, say, 5:30, 6 o'clock at night, that's a long time till 8:30 in the morning for wanting that support network when you're in a stressful situation?
Yes, I mean, I would totally support that observation that when, you know, patients approaching end of life, trying to meet their aims to be supported to die in their preferred place of care, and if that's not in their own home, it would be more in a sort of community hospital, hospice setting. And that is care closer to home, and certainly we perceive, you know, the community hospitals such as Berwick, Alnwick, Holtwhistle as very much providing that holistic care. But we recognise as well that there are barriers for getting patients into those beds, particularly if that need arises in an out-of-hours setting on a weekend, and that's certainly been flagged up as part of our mapping exercise. And on section 3 and section 4, one of the things we'll be looking forward at is actually how we can improve direct access, step up into these sort of more hospice beds for these patients, rather than having to, as you say, go through NSEC, the acute hospital bed, because you know, NSEC obviously has its role, but it's very much about trying to treat a patient, trying to make a patient better, whereas when you approach palliative end-of-life care, it's much more about holistic care, recognising that actually it should be all about symptom control, meeting patients' sort of spiritual needs, psychological needs, and you know, hospital beds such as Berwick, Alnwick, Holtwhistle, they're much more set up for that approach to managing patient symptoms. So yes, we fully accept that, and certainly that is one of our sort of commissioning priorities going forward, identified in this strategy report.
Thank you.
Thank you. Councillor Dodd?
Yeah, I do recall probably about 10 years ago, Councillor Eileen Armstrong did a look into this as a sort of task and finish working group. I mean, I don't know how things compare with 10 years ago. I mean, you know, there was a good death was the one that was mentioned, and one of the things that came out of that was the fact that nothing much had changed in the time that people got access or were taken to, you know, end-of-life care. The time of going in and ultimately dying was very similar to the decades before. And I think what everyone was expecting is a different, you know, with medicine and science moving on, or what I'm trying to say is, are we keeping people alive through science more now? And that was just, say, 10 years ago. And has the COVID figures sort of twisting things now, or is that not relevant to this? And the other one was at the very, very end. You have something called the Death Cafe. What's on the menu? You know, I mean, some will have tea and coffee, but some might just get just desserts. You know. So what does a Death Cafe mean? And I know it's a soundbite, but what does it mean?
But I'll take your question about the Deaf Cafe, and then we can talk about how, in terms of you know, some of the other questions you asked. So really, Deaf Cafes have been set up all over the country, and they're sort of pop-up cafes which allow people to really talk about issues that are important to them, about their preferred care as they approach the palliative end of life, and they're really sort of geared up really just to allow those open conversations for people to talk about subjects which probably are perceived by many as to be taboo, and to open up those conversations. And there will be ways to promote that conversations between people. And they have been very successful when they have been run, not only in Northumberland, but across the country. And it's something that we feel that we should be promoting across Northumberland, because in our community commitments, which we talk about, is that if we're going to achieve delivering the best palliative and end-of-life care to residents of Northumberland, part of that is we need people to engage with those conversations, to identify what's important to them as they approach that time, because only by knowing what's important to you can we deliver that excellent palliative and end-of-life care. And Deaf Cafes are part of that jigsaw to try and identify what's important to people and make sure that their wishes are respected, because that's really important. It's not about what health professionals want to do for patients. It's what patients want for themselves, and how we can support delivering what you as a patient approaching end of life want, or what your family want for you. Yes.
Time of entering, and
Yeah.
is there big change? Are we keeping people alive for longer, or is it just levelled out?
I mean, certainly one of the questions you asked about was, has COVID had a significant impact? Certainly across the country, we've seen that actually COVID did have an impact on death rates. But taking COVID out of the equation, and as we move to a more post-COVID type of environment, I think you're right. The concern would be that medical sciences, is it increasing the time that people live healthy, or is it increasing the time that people live with long-term conditions? And I think that's probably one of the big questions, actually, that we're probably keeping people with long-term conditions alive for longer, but maybe we're not so much increasing the time that people live free of any illnesses. And certainly our report and some of the data work we've done shows that there's quite a lot of discrepancies across Northumberland in terms of the time people get long-term conditions and how long they live with those long-term conditions. And I'm talking about conditions such as diabetes, COPD, which over time might be life-limiting. Does that answer your question?
I'm just come back. I mean, at one time, death was a taboo subject. Nobody really wanted to talk about it.
Yep.
But now, I mean, we see on television, you know, like Jamboree, book your funeral or buy your funeral now, save your family money. It's sort of taken like a different turn. Just an observation, Chair. Thank you.
And I think from the engagement reports that we discuss in the strategy itself, that while you know, many residents are happy to talk about palliative care, the preferences, end of life, there's a significant minority who are uncomfortable talking about it. So in certain segments of the population, it's still quite a taboo subject. And I think one of our sort of priorities from this strategy is actually how can we sort of break down that taboo? How can we open up and have conversations about it? Because that's really important. It's only by understanding people's preferences and what they want can we actually make sure that we address their needs, and that's really important. And you know, the Deaf Cafes is part of that, but that's not the only thing.
Thank you. I actually think, from what I can see, is people are much happier to talk about their funeral than they are about the stage before, the palliative care. I think that's still a difficult subject for people. Yeah.
I think that's undoubtedly right, and as I say, certainly the engagement exercises we've done have flagged that up. We hope that, for example, the community commitment and how we can get that out into the community will start addressing this, because I think it's really important. You know, so I'll give an example. If you want to be supported to die at home, if that's your preference, we need to know that, because we can make sure that we put everything in place to respect that wish, and that's important. But it's only by knowing that can we actually respect that wish. So those conversations are important, but it's actually finding the right time to have those conversations, how you can open them up. So our strategy will be trying to open up those conversations and how we can provide that.
Thank you. Do we have any more questions, Councillor Bowman?
Thank you, Chair. Mine isn't so much a question, but more of a statement. It's a statement of thanks to everybody who was involved in this committee, and obviously the Working Party who put this together. It originates back two years ago at this committee when we discussed the Walton ward in Morpeth, and I was bullied by the chair of that committee at the time to change my vote. And I refused to do so, and each time I refused to do so, I was saying there should be dignity in dying. And because of that meeting and the way that I voted, I was asked to take part in this working party looking at palliative care. And I can tell you now, there's many hours spent going through the data, going through the issues, talking about the communities, talking about all aspects of dying, whether in hospital, whether at home, whether in care homes, wherever it may be. But the core strategy of it was dignity. And that's the key to it, it's dignity. And who derives the dignity? It's the person themselves. And part of it, you would notice, is that if they wish, they can have a private room. And that's basic dignity. You know what hospitals are like, it's clinical care, but all of a sudden we've looked into this. This is palliative care, which is completely different. It takes a hospital's remit, as it were, to change slightly, to actually assist people in their latter moments of life, to have a death that is honest, dignity, and in comfort. And to be honest, when I started on this working party, it was an eye-opener, because I started to see aspects that I had not appreciated. But then when I started to appreciate them, then I started to see how the NHS is a marvellous organisation and how it can actually change to meet the needs of our communities. And this report here is a game changer, because this report is the first of something that will come that will be the norm in the future, but it'll also, from this, other things will happen. I foresee in the future, I don't know, I can't put a timeline on it, but there will be villages where in your old age you might want to go, and palliative care will be part of it. I see that as a normal step. But you see, we've talked about the taboo of dying. People do not talk about death in their families and their loved ones, but they will talk about their funerals and the cost and so on, but they never talk about what happens if my father or my mother or my child even is dying in their last moments. What sort of care, what will happen, where do I get help and assistance, and how will I get support, and how will my loved one who is dying, how will they get support? Where will they be? And this sort of thing. And I suppose what we should be saying to the community, think about these things now. Put them in, like, in your family. Talk about it in your family. So if it ever happens, that your family know what path that you have chosen to take. And I want to just sum up by saying thank you. Thank you for everyone who is involved in this report. Because I'm not kidding you, it will be a game changer. This is what we see on a few bits of paper is hours and hours of deliberation and conversation and basically bringing in all minds to bring out something that is a diamond in our hands. And a diamond in our hands will only shine if this comes into practice, and I'm sure the NHS will take it on board and they will run with it, and it will be like a star in the night. You will see that the NHS in our community will be such a fantastic place, not just to live, but to die. And let's face it, every one of us, every day, is another step towards death. So, thank you.
Thank you, Councillor Bowman, and thank you for, I know the amount of work you've put into this. I was going to say any more questions, but Councillor Dodd's got his hand up again.
Just briefly, thank you for that reminder, Les, that every day is a step towards, but is there, because you know, years ago it was a taboo subject, and I don't know how many people in this room have actually written a will, but that's generally one of the first steps in, because a lot of people won't write a will because they think they're going to die. You know, is there anything in that sort of writing a will? Statistics, anybody look at those statistics?
not sure if that's one you can answer, but if you can,
I
I'd be
don't,
grateful.
we haven't specifically looked at statistics around will writing, but certainly, as I say, it's part of the engagement and how we can get residents to look forward in terms of, you know, their preferences that Les was referring to there around sort of their end-of-life preferences. Will writing would fall into that, but also talking about, you know, advanced decisions about treatment going forward, where would be their preferred place of care, preferred place of death, making sure that they have conversations with their loved ones, so their loved ones are aware of their preferences, because that's really important. So a lot of the emphasis on the strategy will be how we can get those conversations going and facilitate those conversations, because often people perceive there's barriers. People may perceive that their family members don't want to talk about it, or health professionals don't want to talk about it. But actually, it's how we can break down those barriers, how can we break down that taboo and make it much more natural to have those conversations. And will writing will fall into that, but it's as you can appreciate, it's much more than just writing wills. It's about, you know, where would I want to be looked after? In what sort of way would I want to be looked after? How can my wishes be respected? Because that comes down to dignity, which is again what Les referred to, and that's really one of the key strands of this report.
Thank you. Councillor Pattison, you...
Thank you very much, Chair. I just really wanted to echo Councillor Bowman's words and just say thank you very, very much to the team who've worked so hard on this, and in particular Andy and Alan. We had very many conversations about this, and it's lovely to see it come to fruition.
Thank you. Have we got any other questions before I move on? No? Well, I'm going to thank you both very much for your presentation and for the work that's gone on behind it. Thank you for coming to scrutiny to take us all through it. We do have other items on the agenda which you are very welcome to stay for, but if you've got to get back, we also appreciate that as well, and say thank you so much for coming. Thank you.
Thank you for having me. Thank you.
Sorry, item 5 on the agenda, can you hear me? It was the social care at home from Northumberland Healthcare, who coming to present their plans for delivering home care. The Trust have actually asked us if we can not discuss it at this meeting today. I do appreciate this short notice, and I also appreciate that you've all had copies of the slides, and I am aware that you all have questions and comments. So what I'm going to suggest is, you know, we will respect their request, but at the same time, as you do have, I mean, I'm assuming you have questions because many people have said they have. Could I ask you to let Chris have a copy of your questions? And what we'll do is pass them on to the Health Trust and ask them for the answers, or ask them to be prepared for those questions when they do come to scrutiny. Does that make sense?
That seems a good way forward.
Yeah,
Okay.
I would like us to give them those questions because I know that many people did have those, and I would like them to be aware of it. Is that okay? So please do. You've all got Chris's email. If you would just email him with the questions you have. Thank you. Item 6 on the agenda is... Sorry, Councillor Bowman.
Sorry, Chair, did the NHS give a reason why they wanted this item pulled?
I think it was, some of the work was what we could say was limited, and what they could share. I think we are just discussing with them. So that's fine. I am hoping that they will come to a future meeting, but I would like them to have those questions because I know we do have many questions. So So hopefully we can get them to a future meeting. Yeah. Anything else? Councillor Dodd, we were just discussing questions today on the item.
We've had the discussion.
So item 6 on the agenda is... So we have the work programme that's left for 2021-22, and we also have the future programme for the work programme for 22-23. And on that one, I'd like us to have a discussion on what we'd like to see on the agenda. And I think I have spoken to a couple of people who've got ideas, but we are the Health and Wellbeing Scrutiny Committee, not just the health. So if you have any issues as well on the wellbeing, you know, we are responsible for scrutinising services and the health and wellbeing of residents of Northumberland. So I'm happy to take anything to be looked at on the work programme. Do you want to take us through both? Thank you.
Thanks, Chair. So the 21-22 work programme, there's only really one meeting left of this council year, which will be the April one, in which we'll have the quality accounts from Northumbria and NIAS for comment, but it's the 22-23 one that I really wanted to discuss with members today and just get an idea of the sort of things that members would like to see on the work programme. The work programme belongs to the committee. It's up to the committee what they want to see on it, what they want to look at, scrutinise. So it'd be helpful just to get a bit of a steer from members as to some of the issues they want to look at. I know on the 22-23 work programme, on the list to be scheduled is vaping and e-cigarettes, which I know Councillor Hill raised at a couple of meetings ago, long COVID and the move from pandemic to endemic for COVID-19. These are things that will all come from public health, and we just need to find a suitable date for them, but it'd be interesting to know what else members would like to see on the work programme.
So, Councillor Hunter and then Councillor Vilczek.
A couple from last year's was the August meeting. We were to get an update for the NHS partnership agreement early 2022, so to see if we can slot that in somewhere. And the 0 to 19 public health, that was to come back in 6 to 9 months, so we're getting, if we could slot that in. And the one that I was thinking whether we could or not is picking up poverty, like fuel poverty, food poverty, and how it's affecting, you know, all the costs that are going up, how it's helping the well-being of people. I don't know whether we can get something on that.
Just be careful we don't duplicate.
That's not a problem.
Certainly within our remit, I think. Councillor Vilczek.
I was just going to say about young people's mental health, which I think Councillor Hunter referred to.
And also, Councillor Hunter, the restructure of adult social care, which is what I think you meant, is actually on the agenda already. It's down for May, actually, so I don't know if we can get it earlier. No, it was going to be, we were hoping to get it earlier, but I don't think they're yet in a position to do that. I think Councillor Bowman and then Councillor Hill.
Yeah, just to follow on from what you've just mentioned about adult and social care, can we have a look at well, two aspects, mental health, but can we drill it down to mental health for meals as well? Because I know that it is a big problem. It's another taboo subject that isn't talked about amongst men. It is talked somewhat with women, but amongst men, it's very much a taboo subject. So can we look into that as well? Thank you.
Councillor Hill? Yes, it was.
I was just going to add that I presume the escalating international situation is being monitored for what would be relevant for the council across the board, which potentially could impact this committee. But I presume that hasn't been, it's been assessed for where relevant within the council.
I can't answer you on that, although Councillor Pattison may be able to.
Might not all be here next meeting.
I mean, we are definitely looking at this and seeing where it's going at the moment. So yes, we are going to fly the flag. Ukrainian. We're going to do that, and hopefully we'll get a flag tomorrow.
Any others? Councillor Dunn?
Yeah, 2 or 3 things. Antisocial behaviour. I know it's not sort of under the remit, but it comes under drugs. People, I know that some people are sort of trapped in their homes where there's a lot of antisocial behaviour caused possibly by drugs or substance misuse. It's all a bundle that seems to, you know, youth, nothing to do but cause trouble. And I don't know if it's this committee, but it does have an effect on people's health that live in these sort of problem areas. Obviously, I presume we'll be looking at the effect of COVID, mentally, long COVID, but also social habits caused by COVID. I mean, if anybody goes out, you know, the pubs aren't as full, restaurants and things like, you know, what we used to have as the norm is not the norm anymore. So, you know, and do people now drink at home a lot more? Or, you know, has there been a sea change? And I know we're probably not quite there yet, but has there been a sea change in what I'd call social or, you know, just the well-being of people? That sort of get out and mix with people. You know, there will have been a change. I don't know what that is, but something will have changed. I just wonder if we need to look at that in the dark future.
It certainly comes under social contacts and things, doesn't it? People's well-being. Derry.
Up things that both Councillor Bowman and Councillor Dodds have said around those wider.
Can I just add on to that? I know my Councillor Dodds mentioned about drug abuse, which is very important, and it is a core aspect of antisocial behaviour. There is alcohol and there is tobacco as well. We should look into those items as well in our communities. I know that the NHS do a lot on trying to mitigate on alcohol and tobacco by education. We should have a look at that to see what we can do as a council to improve the health of our community. Okay.
Happy with those. We are, as a council, part of the Smoke-Free Councils network. We did sign up to that, that I do now. The other one is I asked to put on the extra care and supported housing strategy to see where we're going with that, but also something Councillor Bowman just said earlier in the thing. We did talk a while ago, or we have had plans, I don't know if Councillor Paston can help, on extra care villages and dementia villages, and that would fit in with what you said about including palliative care. So a sort of long-term housing for older people, it'd be something that'd be quite nice to look at. I don't know if you've got an update for us, Councillor. Sorry.
Well, I'm hoping to have a dementia seminar coming up, and we are in the process of doing a dementia strategy. I'm very keen that we progress dementia, and having a village in Northumberland is one of my aspirations. And so it's identifying where it would be is the crux. But what we'd like to do is to have a site visit. There is a dementia village in Cheshire, so we'd like to have a site visit and have a look at that one.
Thank you. Any others, Councillor Bowman?
Sorry to come back, Chair.
No, I'm quite happy. Keep them coming.
You've picked on another subject I'm heavily involved in, and that's the deprivation of our housing stock within Northumberland. We do have a lot of properties where dampness and coldness is a major issue. These properties were built in the 1960s. They're probably good at the time, but they're outdated today, heated by electricity. Because of the price of electricity, a lot of residents can't afford to build, and the type of residents in these properties tend to be on benefits and so on, so they don't have a lot of financial resources to actually heat their properties. So we're getting health issues coming from that as well. I think we should look into that in this committee. I think it's something that was built in the 1960s by a prominent builder, well known in this region. He probably thought it was brilliant at the time, but we've been left with the problems some 60 years later. And I think it's now that we should look at this as a housing and health issue, and let's get this matter put right. There is an arm to this council that can do housing, as it were, new developments. And if we can do away with these decrepit, old, out-of-date houses and build something that's fit for purpose, eco and cheap to run, and obviously it will improve the health of our residents. But that's a debate for that committee. Is that a good suggestion?
I think in theory it's for another committee, but there's no harm in us having recommendations that come from the health point of view. Yeah. I'm just giving them all to Chris, who'll deal with it.
Can I go on from the fuel poverty, etc., with what's just been said? I remember years ago, the healthiest population of this county was where there was the least central heating, and that was the West Allen Valley. Now, I don't know what, I mean, things is obviously, that was probably 15, 20 years ago. I don't know what's changed in times, but what has changed is opportunity for solar and other things that once it's in, it'll give something back. And, you know, I think we've got in, every build has to have some solar panel now. But, you know, it is worth exploring some of these alternative energies, because let's face it, what we hear, what's coming is that the electric prices are going to nearly double. Now, I don't know if that will come to fruition. I mean, we just need to see the petrol pumps at the minute. You know, it's not looking good. But I think we can, at the end of the day, you know, where would you start knocking down houses and build eco or whatever? We probably haven't got those resources to do the whole lot. But what we can do is make sure that if we said there's a toolkit or there's some sort of assistance in what I'd call using the alternative energies that were not around 20 years ago. So I think we need to look forward, not big stuff, but it's little things that might make a difference.
Thank you. Councillor Hardy. Just to say, we're discussing the work programme going forward, and just ask people to put forward ideas across health and wellbeing of what they would like this committee to discuss. Chris is going to compile them and look to see if they're appropriate for this committee and where we can fit them in. Yeah. So if you've got any ideas. No. Well, if you have, just and on the previous item on the agenda, the trust have not been able to come to discuss it, but we have asked that people, because people have had the slides and do have questions, that any questions you may have on the social care at home from Northumberland Healthcare Trust, that you email Chris with them, and he will compile them and put them to the Health Trust. Yeah. Councillor Vilcheck.
Chair, can just ask on that, can we all receive a copy of the Trust's feedback from the questions? Thanks.
Can I just say about the children and young people's mental health, that's scheduled to go to fax in September.
That's it, right. I have no other urgent business, so that's the end of the meeting. Date of the next meeting is scheduled for the 5th of April, 2022 at 1 p.m. Thank you very much for coming. Can we end this live stream? Thank you.